Hear a lot about data today. It's important, a part of storytelling, but it doesn't tell all the story. And we recognise that behind every statistics lies a person in distress or a life lost, and a cascade of grief amongst family, friends, schools, workplaces, and communities in general. We use this data to do better, to improve suicide prevention and save lives. And it's one of the things that we hear most commonly from our members is the need for data, more of it, more timely, more often. And this key concern of members is reflected in Suicide Prevention Australia's national policy platform. One of our 4 key pillars of reform is data, and that comes from the fact that reliable, timely and robust data can help enhance policies and improve practice all over the country. I should mention that when we surveyed our sector in our annual State of the Nation in Suicide Prevention, 95% of respondents from the sector agreed that their organisation needed access to reliable, accurate suicide prevention data, but only 52% of respondents said that they had access to the data they needed right now. I should note that this is significantly increased from the previous year when we asked the same questions, where only 23% reported having access to needed data. And I do think that the work that the AIHW has been doing has been a really key part of that heartening increase. So it's fantastic to have them here to talk about the data that they have. Before we get into that, I do just have a few brief housekeeping notes. Please do ask your questions in the question bar throughout the presentation, as there will be some time at the end for question and answers. And when you're asking questions, please remember to utilise safe and respectful language and restrict the questions to the topic and presentations for today. By the way, if you feel that your question is not answered, you can email us here at Suicide Prevention Australia and we'll endeavour to answer your questions. And if I could ask that the email for the policy at Suicide Prevention Australia could be put up in the chat so that people have that to answer any questions that don't get got to in this session. The final thing I need to say, perhaps most importantly, is please do reach out to a trusted friend, colleague, or one of the support numbers that we'll be listing in the chat throughout the webinar if you feel that you need additional support. So with that, I'll get on to introducing the speakers. It is my pleasure to introduce our speakers, Chris Killick-Moran and Rosalind Morland. Chris is the head of the Suicide and Self-Harm Monitoring Unit in the Australian Institute of Health and Welfare, AIHW. He has more than 20 years' experience in the development of health policy and evidence in the Australian and ACT governments. His area of specialisations include suicide prevention policy, mental health policy, alcohol and other drug policy, and the use of data and evidence to inform government decision-making. He holds a Bachelor of Arts Honours from the Australian National University. Rosalind Morland is Senior Data Scientist and Project Manager in the Suicide and Self-Harm Monitoring Unit at AIHW. Ms Morland has been working in the health sector since 2015 as an allied health professional before joining the AIHW in 2017. Her areas of specialisation include biostatistics, epidemiology and public health. She currently holds a Bachelor of Human Nutrition and a Master of Nutrition from the University of Canberra and is currently completing a Master of Public Health and Global Health at the University of New South Wales. So with that introduction, I now will hand you over to Chris and Rosalind.
For that kind introduction, Joel. We're just doing a little bit of backroom work here to make sure we get the right presentation screen up for participants today, and hopefully people can see that now. Oh, actually, there we go. Excellent. Yes, welcome everybody to the 4th, I think, instalment of the Data in Practice webinar series that Suicide Prevention Australia have been so kind to invite us to. It really has been a very rewarding process to go through these seminars with sector participants over 2022 when we started these, and we're looking forward to today as well as a few more later in the year that we were just discussing before the presentation started. So today we're going to reprise the introduction to mortality data presentation that Ros and I provided last year as the first instalment. This is intended as kind of a refresher for people who were who participated in this session last year, but also as a sort of introduction for people who may not have been able to attend that original seminar, or who have joined Suicide Prevention Australia since then. So in conducting this introduction to suicide and self-harm mortality data, I'm going to be starting off by talking people through some key concepts and definitions that underpin the way we talk about mortality data in Australia. I'll be having a look at some of the different sources of mortality data that we incorporate into the national monitoring system, and looking at the strengths and limitations of some of those data. And we'll also have an introduction to key mortality data that is contained in the system, and that will be the second part of the presentation that my colleague Ros will be taking care of. So I say this at the beginning of every one of the seminars that we do. I know people, some people find it very difficult to think about data and how they might relate to it. Some people might find it scary. But I can assure you that in any concepts that we're discussing today, you do not need to have any greater mathematical or statistical knowledge than addition, subtraction, multiplication, and division. So we're not even going to hit you with a square root or anything like that. So please don't feel like you need to have a master of mathematics or anything to understand the discussion that we're having today. So I'll start off with one of the underlying concepts that we use in our mortality data, and this is relevant to the morbidity data as well, which is what we use to describe our hospitalizations data and other health collections that are looking at fatal events. And this is a really long title, but it's official, and so we have to read it out. We use the World Health Organization International Standard Classification of Diseases and Related Health Problems, 10th edition, Australian modification. And because we don't like saying that all the time, when we refer to ICD-10-AM, that's what we're referring to. Essentially, the ICD-10-AM is an Australian tailored package of codes for describing almost the entirety of disease and mortality processes in human beings. A lot of it is used for coding non-fatal events as well as fatal. Obviously, for suicide death data, we're dealing with mortality data, we'll be focusing on the codes that are more relevant to death data. And just so people are aware, the series of codes that we'll be looking at in the ICD-10-AM are X60 to X84, which is the bank of codes that look at intentional self-harm. Importantly, and we also include Y87 in our analyses, which is the sequela of intentional self-harm, assault, and events of undetermined intent. I raised that issue because there are different approaches to grouping these codes together. Our analysis is in line with the ABS's analysis and several other major ones. But if you're looking at mortality data that people have published and you can't quite get the numbers to line up, just check the inclusion codes, because that might be the easiest way to explain why you're looking at different numbers. Now I see here that I have included accidental poisoning by an exposure to, which shouldn't be there. I should have taken that out because that's only for morbidity data, because if people die by poisoning and exposure to noxious substances, they'll be in the death codes. So my apologies to everyone, but if you're interested in looking at overdose deaths, overdose presentations to hospitalizations, I'd recommend X40 to X49. Now, a note on intent. It's a very unfortunate truth that ICD-10-AM is not able to code distinction. It's able to code distinctions in the intent of an action as to whether I intended to harm myself, or if I harmed myself accidentally, or if it was unable to be determined as to what the intent of me sustaining the injury was. What ICD-10-AM cannot do is code distinctions in the intended outcome of the action. Now, that might sound a bit arcane, so I'll give some examples. If I have harmed myself intentionally without suicidal intent, we cannot determine that distinction from if I have harmed myself intentionally with suicidal intent, but I have not died by my actions. So it's a very important distinction, particularly in the morbidity data space, where you have we have a lot more cases of people who are injuring themselves without suicidal intent, but for some other purpose, frequently for psychological release of stress or similar events. Mainly in the mortality data, we have people whose intent was to die. There will be small numbers of people whose intent was not to die, but who harms themselves so severely that they did end up passing away. Oh, sorry, and there we go. We do have implications there for interpreting the mortality and morbidity data. So there are two key areas that you'll be able to get access to mortality data, sorry, and we publish from both of these. The Australian Bureau of Statistics causes of death, 3303 is the publication number, and the AIHW National Mortality Index, which is derived from the causes of death publication, but has a few little things taken out and a few little things that are put in for the purposes of most people in this conversation. You should treat them as equivalent. These collections have attracted a bit of criticism over the years. They're published about 9 months after the end of the reference period, which in both of these cases is a calendar year. There was a revisions process introduced in 2006, whereby the ABS published preliminary data in the year of release. I'll go back and revise that data the following year to see any cases that have come through from the coronial courts that weren't finalised in the first year of reporting. And then 3 years after revisions have started, they describe that as final data. This was to overcome a problem that was emerging in the early 2000s, where there was a slight artifact in the data where coroners' courts were beginning to take longer periods, particularly for some ambiguous cases. Particularly, this occurs in situations like overdoses or single vehicle motor accidents, where it can be very difficult to determine the intent of the action. So what we found was that more and more cases were not being counted and were lost to the data collection because of the reporting in single years. This revision process has now really improved the accuracy of that data. What it hasn't improved is the timeliness of that data, which is a key limitation of this particular data set. What is the strength of this data set is that it is epidemiological grade, final causes of death data integrated with the entire causes of death collection, and is the basis for all of our national and international reporting. One just last important distinction to make in these collections is that there are dates that are reported as year of death event, and there are data sets that report on the year of registration of the death, which is when the death has been finalised. The death inquiry has been finalised by the coroner and a determination has been made. As you can probably gather from my descriptions earlier of the revisions process, these can be quite some time apart. So another important thing to keep an eye on if you're looking at things that feel like they might be the same data, but you're getting different numbers, is check if people are reporting on year of death or year of registration. And there are reasons why you'd use one or the other. The ABS generally reports year of registration, and we generally follow that pattern. Okay, another thing that's happened over the last couple of years, and it's been really interesting to watch this unfold, is that there are now state and territory suicide registers in all states and territories with the exception of Western Australia. And if people caught the news in the last month or two coming out of Perth, the government there have announced that they will be moving to develop a suicide register there. They've got some legislative processes they need to go through with their Coroners Act before they can do that. The difference with a state and territory suicide register is that it's not counting final determinations by the coroner. It's counting deaths that have been referred to the coroner as suspected suicide deaths. The benefit of counting these cases is that we're able to get access to information very quickly, usually within 24 to 48 hours of the death event. And what that does mean is that we can work with the states and territories to monitor that data and see if there may be some emerging patterns of concern much more rapidly than we're able to do with the final ABS data. If any of the people listening today were able to catch our symposium at the Suicide Prevention Australia conference, you may have been able to see some of the work that Matt Spittle and the University of Melbourne have been doing with the Australian Institute of Health and Welfare and the Coroner's Court in Victoria, where we've developed a system that's able to look at some of those referrals coming in to the Coroner's Court, and we think we can start to detect spatiotemporal clusters in that data, depending on the scale of them, within up to 2 to 3 weeks of them starting to form. Now, that's obviously much more useful and much more actionable than looking retrospectively at data that may be between 9 and 18 months old. However, because we're looking at suspected suicide deaths, there will be some deaths in there that have been referred as suspected suicide deaths that will be determined were not, and there will be some deaths that were referred as an accident or an assault that will end up being coded to suicide. That said, we generally have a pretty high level of concordance with the final data. Some analysis out of the Coroner's Court in Victoria suggests that it might be about 95% accurate, which, if we're using it to get a general idea of what's going on earlier, we think is actually a pretty good compromise. And that's me over. I'm now going to hand over to my colleague Ros, who will talk you through some of the data that we have in the system. And I'm going to sit back and monitor the chat line and help steer through any questions that come up in the chat line.
Thanks very much, Chris. So just before jumping into a tour of our mortality data on our website, I just wanted to quickly go over how we measure suicide, particularly over time. So I have an example up here. If you were in this webinar last year, apologies, it's a bit of a repeat of that, but it's always good to refresh your knowledge. But for anyone else, I'm just going to use an example from the ABS causes of death data on our website, and I've just filtered the visualization from 1990 to 2020. Okay, so the number of deaths by suicide in the year 1990 was 2,360. In 2020, it was 3,139. Sorry, just move this down. So what this is, this to us now looks like a 33% increase in the past 30 years of suicides, which is fairly large. So should we be panicking? Not yet is the answer. So let's just stop and think about what else has changed over the past 30 years that might explain this increase. So since 1990, the population has increased from around 50%, from 17.1 million to 25.7 million in 2020. And the age distribution of the population has also changed over time due to people living longer, changing fertility rates, migration, and various other factors. So in summary, the population in 1990 is very different to 2020. So we need to adjust for these changes, otherwise we're comparing apples to oranges. So how do we do that? With age standardization, which is a common practice in adjusting for different age structures between populations. Age standardized rates are hypothetical rates that would have been observed if the populations being studied had the same age distribution as the standard population, while all other factors remain unchanged. So, for example, Here's my example, there it is. The age standardized rate of deaths by suicide in 1990 was 13.9 per 100,000 population. This means that there was an average of 13.9 deaths by suicide per 100,000 people in 1990. The age standardized rate of death by suicide in 2020 was 12.1 per 100,000 population. So the rate of suicide actually decreased by 13% in the past 30 years. So what we did here is that we removed the effect of the changing populations and made the 1990 population and the 2020 population more comparable. So now we're comparing apples to apples. I won't go into the specific methods or maths behind it, but just know that when we are talking about an age standardized rate, which will come up a lot in this presentation, it means we are looking at a standard population across time to allow comparisons between populations. It also removes the effect of age structures or the effect of age and event. And you'll see the exception to this is when I talk about age-specific rates, which I'll get into when that pops up. Okay, so we have a lot of mortality data on our website, like a lot. It's the bread and butter of what we do. So this is just an overview of what I'm going to be talking about today, and I'll give you a live demo of the website. But as you can see, there's a lot, and there's actually a lot more than this on the website. So in any one of these, I could spend an entire hour and a half webinar on just one of these. There is a lot of information in each page, so please go and have a look. And just a reminder to self-care following this presentation or even during, if any of the things I talk about today bring up any feelings, feel free to jump out or come back in, whatever you need to do, and make sure you self-care after the presentation. So just bear with me while I hop over to the website. I just hop out of this slideshow. Okay, there's the website. Okay, so this is the AIHW website, and we're very special. So we have our own sub-site sitting on this website, and you can see that by highlighting reports and data and just clicking here on suicide and self-harm monitoring. And there's some other sub-sites here too, which are very interesting. If I click on that, the first time you click on this, you get a little pop-up saying, you know, be careful reading this information, but I'm on this website a lot, so I don't get that pop-up. And this is our home landing page. But what we're going to go through today...
sorry to disturb you, but I don't think the website is showing.
Oh, sorry. Sorry about that. That's just a user error. Thank you for letting me know. Ooh. I think when I closed I thought I was sharing the screen, but when I closed the, this is what I want. One profile. I think this is what we want. Okay, I'm so sorry about that. Let me go back and quickly show you. When I closed the PowerPoint, it also closed what I was sharing, so my apologies. I was just saying when you hover over reports and data, you can see our sub-site here on the AIHW website, and that takes you straight to our website. But we're going to be focusing on this data tab here. So let me just hop over. So the first visualizations I wanted to look at today were the state and territory suicide registers. So Chris mentioned this briefly, but the data from the suicide registers are based on initial police reports and other information available at the time of the referral to the coroner, and they are not directly comparable with the ABS data that we're going to look at, which are based on final coronial determinations, as Chris mentioned. But however, the differences are usually quite small. So what I've got here, we're looking at the New South Wales suicide register data. I've got it set to cumulative frequency, which is just adding on month by month the number of suspected suicides. So what I can do here, I can highlight a specific year. So I'm going to highlight 2022. So we're looking at January, and this is what I mean by adding it up month by month. Went from 80 to 153, so that's January plus February, and then that March is January plus February plus March, and so on. And we can see that 2022, in comparison to previous years, the numbers are a bit higher, noting that these are numbers and haven't been adjusted. And for 2023, we only have data for January and February so far, but it's already looking like it's following a higher trend as well. So we'll see what we get in the coming months. We can also swap to just looking at the straight frequencies. Let me just unhighlight that. So yeah, you can kind of see across the months, the general trend of 2022 tends to be a bit higher. Okay, let me hop out of this one. So we also break it down by sex and age group. I wasn't going to go into this today because I could be here all day on this page, but please do go and have a look. I'm just going to hop over to Victoria. So a little bit similar to New South Wales in that 2022, if I hop over to cumulative frequency, there we go, and I'm just going to highlight 2022. We can see that 2022 was a bit higher than previous years from around August. Oh, okay. Apologies. I will slow down. There's a lot to get through, hence the speed, but I will go a bit slower. And we can also see that 2023 is again, compared to previous years, is trending a little bit higher. Okay, so I'm going to move on from suicide registers, but like I said, there's a lot of interesting data on there. We also have some data from other jurisdictions, so please go and have a read. The next one I'm going to hop over to is one of my favorite pages, Death by Suicide by States and Territories. I just like it because the visualizations are very nice. Oh, sorry, hang on, I've jumped ahead. One of my pages is missing. That's okay. I will give you a live tour on how to get there. We're not going to states and territories. We are going to deaths by suicide over time. Apologies, the tableaus are a little bit cut off. I think that's just because I'm on my laptop, but we can just go into full screen mode, and that fixes the problem. So now we've done state and territory suicide registers, so now we're hopping into that ABS causes of death data that Chris was talking about before. And this page provides a lot of insight into that data, and it's updated annually every year when we get that new data. So this visualization just represents suicides over time from 1907. And what we can see is that males are consistently higher than females. That's represented by this blue line here, females being this bottom purple line, and we have persons in the middle. So because males are consistently higher, variations in overall suicide rates, this person's line here, is largely driven by changes in the male suicide rate. And it is important to note that although males are more likely to die by suicide, females are more likely to attempt suicide, and that's reflected in our hospitalisation and ambulance data, which I'm sure we'll revisit at some point in a future webinar if you're interested. Now, while the reasons for an individual's suicide death are complex, the overall peaks and troughs that we see here in rates and numbers tend to coincide historically with social and economic events. Just do be careful because correlation is not causation, but that's just the general pattern we see. So on that note, there are 3 stories in this time series I'd like to highlight. So the fall in male suicides here and here coincide with World War I and World War II. And these falls attributed in part, in fact, to that all deaths, including deaths by suicide of Australian service personnel, occurred overseas and were not included in Australian death registration data. And the population estimates for these years were not adjusted to allow for the absence of these personnel. So that's why we're seeing dips here. So we can't see them because they were overseas. The highest age standardized rate for males occurred in 1930 at 29.8 deaths per 100,000 population. And that was during the Great Depression, which was a period of high unemployment, particularly among males. There was an increase in suicide rates for both males and females in the 1960s. So around here, we can see that here, particularly in females. And that's in part attributed to the unrestricted availability of barbiturate sedatives. And these are a group of drugs that induce sleep or lower anxiety, but are very dangerous and difficult to prescribe safely. And overdoses can cause coma or death. And we saw a fall in suicides around the late 60s. And that was when there was an introduction of the restrictions to the availability of those barbiturate sedatives in July 1967. There was some higher suicide rates around the 1980s and the early 90s, and this coincided with a period of economic uncertainty in Australia. Now, while these are the latest data we have, and it will be updated later in the year to 2022, we can't see here any effects of COVID-19 in 2020 and 2021, and that's reflected in the data from the state and territory suicide registers as well, where we didn't see any trends in those data either over COVID-19. But as you saw when we were looking at the suicide register data, we did see some increases in 2022. So this will be really interesting when this is updated later this year. Just one more note, Chris touched on this on his introduction, that from 2006, there was a change in the revisions process, and that enabled the revision of cause of death for open coroner's cases over time. So what I mean by that is prior to 2006, there it is, prior to 2006, we have a general idea of suicide trends. After 2006, we have a much better idea as the data quality is improved. Okay, so I'm just going to scroll down now to age-specific rates. It's a lot of information on this page, as you can see. Okay, so now we're looking at the age-specific rate, which I mentioned briefly in my introduction, but they're a little bit different to age standardized rates. So age-specific rates are calculated in the same way as a crude rate, which is where we just take the number of suicide deaths and the denominator is the population restricted to an age group. So we don't need to worry about adjusting for different changes in age structures because we're looking at specific age cohorts now. So it's a bit simpler than the age standardized rates. So I'll just pick out some of the ones standing out here. This is for 2021, but in this visualization, you can go back as far as 1907. Males aged 85 and over stand out straight away as having a very high age-specific rate at 36.4 per 100,000 population. However, when I swap to numbers down here, we can see that the absolute numbers are relatively low in comparison to other age groups at 76. So you're going to see this come up a lot in a lot of the visits today, that when you have small populations, the population for males over the age of 85 is quite small, and the number of suicides is quite small, you see fluctuating rates because the any changes in the rates make it look quite high. So it's really important when you're looking at age standardized rates to also take into account the absolute numbers when you're interpreting that data, because males over the age of 85, like as I mentioned, it's a small population and a lot of them die of other things as well. So just keep that in mind. I'll just hop over to age specific rates again. So some other high age groups for males around the Middle Ages, particularly in the 50s, as well as the mid to late 20s. For females, we do see the high rates in the 85 plus, but that's a similar reasoning as I explained before. Small population, fluctuating rates. Make sure you take into account the absolute numbers. But a similar pattern in females, for around females in the Middle Ages and 50s, and the low to mid 20s also. I better keep moving. If I am still going too fast, just let me know. There's just a lot to get through. Oh, and sorry, I'll just mention one more viz on this page. There is a visualization, which I'm not going to show today, which shows the trends in methods used for suicide, which have changed greatly over time as restrictions to the availability of some methods are introduced and new methods become available. So, for example, I mentioned before the unrestricted availability of barbiturate sedatives in the 60s. And in this visualization, you'll see a decline in the number of deaths due to that. And then some other ones that come to mind are gun control reforms in 1996 after Port Arthur. So you see a steep decline in suicide by firearms. If you'd like to explore this data further with us, feel free to contact us and we can take you through it offline. But I'm just not going to go through it today. Okay, so now we're looking at states and territories. So let me scroll down. Oh, and I've Tableau's just needs a moment. It often does. Refresh this page. I have backup screenshots if Tableau doesn't play nice today. There we go. There we go. Okay, so the default view has disappeared for us, but that's okay. I think this mouse isn't working well. Hang on. That's okay. I'll keep moving. I was going to say, there we go. That's the default view. I was going to say, since our last update, and if any of you were at our last seminar, we have tried to improve the interpretability of this viz by de-spaghettifying it a little bit, which is the technical term. And what we've done is when you first log on, you just see Australia highlighted. Because this visualization is a good example of what happens when you start to drill down on suicide numbers from a national level. We were looking at a national level before, and now we're splitting it up by state and territory. But even at the state and territory level, we see large variation in rates because the suicides are a relatively rare event and they're small numbers. So even a small change in those numbers cause fluctuations in rates. So if I highlight Northern Territory, for example, we see very wildly fluctuating rates. They're all over the place, and even some points aren't published because the numbers are too small. So when you're looking at data like this, it's really important to look at the overall trend, which stays pretty steady. And when you swap to numbers, I'll just swap from rates to numbers. So we can see that Northern Territory is right down the bottom. basically what we're looking at here are population sizes. So New South Wales, being more populous, is up the top. So again, important to take into account absolute rates when looking at these. To the next one. So the next one I'm going to hop to is the birth cohort study, which is a really interesting analysis. Just make this nice and big. Apologies, I don't have the full screen option on this visualization, so just bear with me. But what the birth cohort study is, it shows how suicide rates have changed for people of the same age but born at different times. And each one of these lines, just scroll across. A little bit hard to control with this mouse, apologies. So each one of these lines represents a birth cohort group. And down here we have the age group. So we can see how suicide rates have changed for people born in a specific age cohort. So I'll just pick an example. I'm just going to pick this age cohort. This one is my age cohort. So these aren't the latest data. We are working on updating this, but for this is males. That's all right. I'll stick to males. So we can see for males in this age cohort, we can see how when they were aged 25 to 29, how they compared to other birth cohort groups when they were the same age. So if you were born in 1959 to 1963, you had higher crude rate of suicide compared to males born between 1989 to 1993. Scroll down, there is another way of looking at this. This is basically the flipped version of that previous visualization, where you can follow each line is an age group. It's very interesting, and it's just really interesting to see how suicide rates have changed over time. So one example in females, for example, the suicide rate at the age of 15 to 19, that were born more recently. This is 1.8 times higher than the earliest cohort born in 1954 to 58, so down there. And this pattern wasn't observed in males of the same age. So it's just a really interesting study for picking out how rates have changed over time. I'm going to keep moving in the interest of time. Okay. All right, so now we're looking at deaths by suicide by remoteness area, and I'll make this one nice and big. There we go. So what we can see is that the rate of suicide fluctuates a lot with increasing remoteness. So we have major cities. Ooh, something went wrong there. That's okay. Major cities, inner regional, outer regional, remote, and very remote. And what we should look at here is the overall increasing rate of suicide as remoteness increases, with it being higher in the remote and very remote areas. But if we swap to numbers, you're basically seeing the effect of population sizes on the number of suicides. So that, yeah, it basically flips, with major cities being at the top, but that's just because there are more people. So you're just looking at a higher population. So again, keep in mind the absolute numbers, and that's why we see quite wild fluctuations in very remote, because that population is very small. So any change in numbers looks like a large change in suicide. Okay, so next we have primary health networks. Make this big. We have a range of different geographies on the website. This visualization, again, we've de-spaghettified it. we have the Australian, the pink line is the suicide rate in Australia, and then you can select your primary health network. So I'll just select ACT because that's where I am. And you can just see how your age standardized rate of suicide compares to Australia or other PHNs. So this can be useful if you're working for a PHN and you just quickly want to be able to grab what are the suicide rates over time and how does that compare to Australia or even other PHNs. It's there. So all these data, I should have mentioned earlier, all these data are available for download in Excel tables as well. Okay, keep moving. This is death by suicide by local areas. So this is using our mapping software. Oh, sorry. Zoom in. Struggling a bit with the laptop mouse, bear with me. Oh, for goodness, zoom out. There we go. Okay, so first of all, the grey areas, the blank areas, just need to acknowledge those. That's where we don't have data, and we are working on improved data quality all the time. And it's also another example, like I mentioned, with the state and territories and any of the geographies, of how it can be difficult to disaggregate or drill down on suicide data to lower levels because it becomes unpublishable. In these cases, the rate is too small because there's only a small number of deaths, and it's just not possible to. We have rules around what we can and can't publish, and that has unfortunately become unpublishable because you have very big areas with small number of people living in them. So I'm just going to demonstrate how these maps work. So basically you can hover over any area and you get some information on that area. You can also change the layers of the map. So for example, if I wanted to look at males by statistical area 4, which is just a slightly different level of geography. And if I click on an area, and now I can see males specifically at statistical area 4. But just generally, let me close out of that. Sorry, I should mention, because we are disaggregating by statistical areas, we've had to aggregate the years of the data. So it's aggregated to 2017 to 2021. Otherwise, the numbers become much too small to publish. Just scroll up. And over that 5-year period, the 2017 to 2021, we saw the highest levels. I'll just get rid of my males layer so we can see that. There we go. Just in general, we saw the highest levels in areas like the Kimberley in Western Australia, and we saw lower rates of suicide in areas of Sydney. I'll pull out what areas they were. That was areas such as Baulkham Hills, Canterbury, and Blacktown. So these maps are really great. We have maps for different things on this website, and they're very, very useful. So please do go have a look and have a play. So I'm going to move on to international comparisons. So let me just make this nice and large. Oh, I cannot make this one large, apologies. So this visualization here is a little bit cut off, so I'm just going to move that across. There we go. We are comparing Australia's suicide rates to the international data. So we have G20 regions and WHO regions. And in this visualization, you can click on these tabs and you can change in and out what regions you want to see. I'll just stick to this main page now. And so it gives us an idea of where Australia sits with the rest of the world, which it looks high in comparison. But it's really important to keep in mind that while this is a very nice visualization, the rates are not directly comparable with other countries due to different counting rules, data quality, and several other factors that might impact suicide rates. So, for example, in other countries, suicide is quite taboo, and doctors may be less inclined to write them on death certificates, and thus suicides aren't counted. That's just one example, and that's more the case in developing countries. But what this is really reflecting is that Australia is actually really good at counting suicides. And that's why it looks relatively high, because we actually count them. So I'm going to keep moving now, but that one is quite interesting. Now we're moving into population groups. So this visualization is, suicides among young people. Just make it nice and big. There we go. So suicide is the leading cause of death among Australians aged 15 to 24. But one of the reasons for this is that the proportion of deaths by suicide is relatively high due to the fact that these age groups don't tend to die from other causes. So again, keep in mind the absolute numbers. So deaths by suicide represented 34% of all deaths in young people aged 15 to 17, and 35% of all deaths in those aged 18 to 24. Again, that sounds quite high, but that's just because they aren't dying of other things like chronic conditions. These proportions have increased from 2001. So there was an increase of 17% in the 15 to 17 group, and an increase in 24% in the 18 to 24 group in the proportion of suicides in comparison to all deaths since 2001. In children 14 and below, the proportion of deaths by suicide is much lower compared to the other age groups, with 2.2% of deaths represented by suicide out of all deaths in children aged 14 and below. So it's much lower. We are seeing some increases in those other age groups. I'll just keep moving. Okay. So the next population group I wanted to show today was the Indigenous population. Laptop mouse, there we go, full screen. So it's very clear that the rate of suicide is much higher among Indigenous Australians, represented by this green line at the top, than non-Indigenous. Unfortunately, monitoring suicide in Indigenous Australians is challenging due to data quality issues. So analysing any trends for Indigenous Australians needs to be interpreted with caution. And this is due to the under-identification of Indigenous people in deaths data and the uncertainties in estimating and projecting the size and structure of the Indigenous population over time. So age standardised rates that we're looking at here are based only on a small number of deaths. Thus, as we can see, they do vary significantly over time, much more than the non-Indigenous. It looks much flatter on this line, while this line tends to have more wild fluctuations, and that's just because of small numbers. As identifying Indigenous status among deaths data improves, it may, at least in part, account for some of the rise in the case and numbers of rates. So that's important to keep in mind too. So some increases might just be because we're identifying Indigenous people better in the data. But having said all of that, the age standardised rate is about 2.3 times higher for suicide in Indigenous people than non-Indigenous. And we have a univariate regression model that also estimated the risk of suicide was about 2 times higher in Indigenous status in Indigenous Australians compared to non-Indigenous. So it's just a very good model because it's reflective of what we're seeing here. Keep moving. Okay, so the next visualization I've got up, I think we can make it bigger. Sorry, I'm just a bit struggling with this laptop mouse today. There we go. Oh, yeah, thanks. So I'm just going to steal a mouse from Chris because this mouse isn't very good. Thank you. That one's terrible. Ah, it's much better. Okay, so we have, there is an area of AIHW that solely focuses on suicide, veteran suicide, and they have their own space on the website. So please go check that out. However, we do have some data on our website. And what we're looking at here are the ex-serving Australian Defence Force males, but you have a few other selections here. And what we can see is that they are at a higher risk of suicide than male reserve or permanent members, which are represented by this green line. And ex-serving males are 24% more likely to die by suicide than other Australians. And for ex-serving females, it's twice as likely. So there's a lot to go through in this visualization, so have a good look. But as I said, there's also a veteran suicide area in AIHW, which produce some very interesting reports. Okay, we are almost there, guys, so well done. The next one I'm going to look at is a new one that was made by someone in our team. I think she's online with us today, and she did a great job. So what we're looking at here are the rates of death by suicide among disability service users compared to the general population. And this is between the years of 2013 to 2018, because that's when this study was run. So in the purple, we have disability service users, and it's important to note that these are people who used disability services. So it doesn't represent everyone who had a disability, just those who use disability services. But we can see the rate of suicide, or the rate of death by suicide, is significantly higher in those who used disability services compared to the general population. I'm going to hop to a different visualization. And just as while I'm hopping to a different visualization, this is one of our priority populations that we were exploring, and we'll go more in depth when we do a webinar on priority populations, because this is a fascinating webpage. I could spend all day on it. Maybe another 3 webinars on this page alone. It's very, very interesting. So I'm just giving Tableau a second, and I pulled up the wrong visualization. This was the other one I was going to show today. Similar to the one we looked at before, we're looking at age groups, and we have the general population, disability service users, and then we have disaggregated a little bit further by looking at disability service users with a psychosocial disability. And the rate of suicide among those are much higher. So a lot of those higher suicide rates in the disability service users, this visualization is showing that it's those disability service users with a psychosocial disability is a key driver in those increased rates. And we can see that in another visualization on this webpage, where we break down when we're just looking at those who use disability services, what their primary disability was, and there was a large proportion that had psychosocial disabilities. I would love to jump into this more today, but we just don't have the time, so I'm going to keep moving, but please come along to our next webinar where we'll go through it in greater detail. Oh, and I accidentally just closed one of my tabs because there's something in the way, so we will work around that. I was going to hop to, I'll hop to this one. Perfect. Okay, so we're going to look at deaths by suicide by socioeconomic areas now. This visualization does have a content warning on it because there are some mention of methods of suicides, but I'm not going to look at that today. So, oh, is it going to let me in? Yep. Okay, put it on full screen. So what we can see here is that there is a clear difference between the socio-economic areas for suicide. So quintile 1 is the lowest socio-economic area or the highest area of disadvantage. And we can see that the rates of suicide over time is higher when we compare it to the highest socioeconomic area, which is also the lowest area of disadvantage. So no surprises here, really. Okay, I'll hop over to, this is the one I intended to do before I closed the wrong tab. We're looking at psychosocial risk factors and death by suicide, not to be confused with the disability one we just looked at, where we looked at disability services with people who access psychosocial disability services. Here we're looking at risk factors that were coded with the deaths, and we're looking at females and we're looking at all ages, but you can change it and toggle it however you'd like. And what we're seeing is among those who died by suicide for females, 33.2% also had a personal history of self-harm. And then there was a proportion, 12%, who had problems in a relationship with spouse and partner, disruption of family by separation and divorce. So this visualization isn't at all saying that the presence of one or more of these factors in a person's life, it doesn't necessarily mean they'll have suicidal behaviors. So please don't interpret it that way. The vast majority of people who do experience these risk factors will not experience suicidal behaviors, but it really is interesting and important to look at these factors next to suicide to give us information, and it's important for interventions and service planning as well. So we just hop out of that. There is one more to go through, which is, what are we looking at? Deaths of despair, which I might have closed. No, I didn't close. Here we go. This is the last one for today, so well done, everyone. So, deaths of despair. Where this has come from is that there was an observed increase in the overall mortality of middle-aged white non-Hispanic people in the United States due to deaths by suicide, drug and alcohol poisonings, and deaths due to chronic liver disease and cirrhosis. And together, these causes of death were termed deaths of despair by the authors Case and Deaton. They linked this trend to a decline in economic security and a lack of universal health care and the widespread availability of opioids in the US. So we found this very interesting and wanted to investigate these deaths of despair in Australia, and found that Australians are not increasingly dying to these deaths of despair over time, unlike America. So the rates of combined deaths by suicide, alcoholic liver disease and cirrhosis, and accidental poisoning over the period of 1997 to 2021 show no clear trend. But it's still really interesting to monitor and explore. And we just don't have the same problems and populations that they were seeing over in America, such as lack of universal healthcare or economic insecurity. I'm going to stop sharing my screen, but though that concludes the end of the data we were planning to go through today for the mortality data. As I mentioned, there is a lot on our website, and it's already 3:10. You can see why I had to get through that. But please go and have a look, because there's a lot of great information on that website that dives in much deeper than I was able to dive into today. So Chris, I'm going to hand back to you now.
Well, thank you very much, Ros. Always great to see our website being driven around for education of our sector colleagues, and I have to say there's been some great chat going on in the side panel. I think I've managed to get across most of the questions. I've just got one from Joshua that I'm about to respond to around bereavement. So what I might do is just hand back over to Chris Stone to see if there's any verbal questions that people on the line would like to ask us.
Thanks very much, Chris and Ros. And look, we really appreciate you taking through that wealth of numbers that you have. Yeah, I'm about to open it up to question and answers. And what I'll be doing is I'll capture some of the questions in the chat that Chris, you might have missed. You did a sterling job of getting to most of them, so thank you for that. And also, if we also have some pre-given questions, which I'll take us through, and then if we have time, I'll open it up to verbal questions. But please continue putting questions in the chat while I'm talking. Just before we do go into the question and answers, I did want to pick up on some key points of that presentation. I mean, all of it was interesting, but I think the first thing that really struck me was de-spaghettification as a technical term. But
patent pending.
Yeah.
The other thing I wanted to note was, and was mentioned just briefly, but the increase in suicides in the latest data we have in the state registers, which is concerning, and it is something that Suicide Prevention Australia has utilised in our conversations with government in our advocacy to try and get more attention on this issue, which is just an example of how this data can be used. I did also want to pick up on the issue which Chris has already addressed on data on suicides in LGBTIQI+ communities. You know, this is obviously a really important area, as are all of the priority populations, and it's really great to see that there's further work being done on priority populations. The disability data that we got to see so briefly was really excellent, and so yeah, as was mentioned, we're going to be doing another presentation specifically focusing on that data. But look, I'll now start going through some of the questions. Chris, one of the ones we got early on in the chat that I think you may have missed was, will the death be recorded as a suicide if the family don't want the death communicated as a suicide?
Okay, I thought I'd responded to that, but I'm happy to just reprise it. There's a discussion, and Ros touched on this in the international comparisons part of her presentation, that social stigma, whether that's religious or cultural stigma around suicidal behaviours, can affect the way people interpret the evidence that's in front of them in making a determination around whether a death is a suicide or an accidental death. And I can imagine in Australia for deaths that were very ambiguous, that may enter into some of the thinking of the coroners. But I've actually raised this with court staff at a number of coroners' courts, and every time I have discussed this with people who work inside the coroners, they tell me that in 10, 15 years of working directly with coroners, they have never seen a time when a coroner has changed the determination of intent due to concerns by the family.
Great, thanks, Chris. Look, another one's just popped up in the chat. You may be able to see it, but just regarding the Indigenous suicide rate, could you clarify what the rate is per 100,000 in the Northern Territory, if possible, and how it compares with the non-Indigenous population in the Northern Territory?
I think we can. I don't think we've published that, but we can find it. It will be in the ABS causes of death data, which, you know, it always makes me wonder, should I just keep this saved on my desktop or?
No problems. And look, I can give you a chance to look at that now, or we can provide it later, but I might just I'll move on to some of the other questions we have, if that's all right, and we can come back to that one if you get it.
I'll be looking that up while you're reading out the next question.
All right, that sounds good. Now, the next question is possibly more of a policy than a stats focus, but I'll put it to you, is that how can we adopt a solution-focused approach consistently in this space?
Now, okay, I think I know in your intro to the session, Chris, you did mention the amount of time I have spent working in policy in various health departments. In my current role, I'm bound to simply comment on the data, interpretation of the data. I really can't make any comments on the way that suicide prevention practice or interventions or policy should be framed. So if you'd asked me 4 years ago when I was working in the Department of Health and was responsible for managing funding programs there, it would be a different story, but I'd have to leave that question go, I'm afraid.
No problems. I do understand that. Look, I'll move to the next one. You may not be able to answer this either, again, but I'll put it to you anyway. The question is in regards to early intervention in children, and is there any comments you can make on that from a statistical point of view?
Oh, certainly. Look, again, without I mean, early intervention for young people, high schoolers, primary school age children, has clear efficacy across a whole range of outcomes in the health and welfare sector. There's no debate about that. I think some of the material that Ros touched on around the psychosocial risk factors, particularly around survivors of child abuse or neglect, or people who are, young people who are involved in a family that's experiencing domestic violence or marital breakdown. They're very clear identified risk factors. So it's through the use of data like that that we can start to think about what precisely should we be targeting for our young people to minimise the effect, the potential effect of some of those adverse life events on them later in life. But of course, if people want to go and have a look at the census variable regression model that Ros mentioned, education retention provides a very clear social gradient around relative risk of death by suicide, and that's whether that's controlling for other factors as well. So I mean, keeping young people in education, whether or not it has an influence on their eventual employment, in and of itself is a protective factor. I hope that's just a few observations.
Yeah, no, thank you for that, Chris. And it's and I should mention from my own perspective, Suicide Prevention Australia is currently engaged in some research looking at the social and environmental determinants of suicide. We certainly found it very helpful. We certainly found it very helpful to have the data that we do, which enables us to look at some of those factors and how they relate to suicide. For the members that are in the audience, by the way, we have previously sent out messages about our work on social and environmental determinants. So if you go back through your member brief and you want to comment on that, please feel free to do so. Now I've now come to the end of the written questions I have. Please feel free to put any more in the chat. I will just come back though to Chris and Ros about whether I see that the answer to what I was just about to ask has cropped up. That's the answer there. Thank you. Did you want to say, Ros or Chris, anything further on that that particular statistics around Indigenous people in the NT?
No, I'll just pull up the. So people were able to see when Ros pulled up the states and territories analysis that the suicide rate in the Northern Territory varies enormously because of it's consistently elevated compared to the rest of the country, but in comparing it to itself, it does fluctuate quite wildly. The last year that we have complete data for, the whole population rate is 20.6. That does include Indigenous people in the whole population. So we haven't actually separated Indigenous people out. So the whole of the Northern Territory comes in with a result of 20.6, and that was in 2019. So if you look at the notes that Ros just posted there at 30.9, that's about 50% higher, and that's relatively consistent with what we see about the relative risk for death by suicide for Indigenous persons across the country.
Yeah, and that's, oh, sorry.
Yeah. Sorry, I was just going to point out, sorry, just a slight correction. The reference period for that is 2017 to 2021, not 2021. It's been aggregated into 5 years because of small numbers. So I'm just going to post a correction.
Great, thank you for that, Ros. And certainly that's a worrying statistic that even with the Indigenous population included in the overall population number, around 30 versus around 20, and it would be an even bigger disparity were we looking at the non-Indigenous population, obviously. Yeah, so that's concerning. Right, final chance for anyone to pop a question into the chat before I go and close up this session. Is there any final questions? I will give you just a moment to finish typing if you've got something. No, all right then. Well, look,
Chris, I might just finish up with one comment. I think it was Josh who asked around the number of people who are bereaved by suicide, and I'm just looking at. I responded that not to date bereaved persons are a priority population, but we're still thinking about how we might actually measure that. And I just wanted to let people know that during the conversation, I've actually had a few ideas about how we might do that now that that question's been asked. So I'm going to go back and have a chat to the team and see if we're able to provide some insight to that when we catch up in a couple of months.
Oh, fantastic. And it's great to see that these sessions are influencing your work in that way. So that's fantastic.
Absolutely.
Yep. Look, all right, I'll finish up at this point. I did want to obviously finish by thanking our speakers, Chris and Rosalind, and thank you to everyone who's joined us today, those who participated and gave some questions, and those who were just listening and learning. We hope that you'll join us for the next webinar in this series, which from the sounds of things, most of you will. There seems to be a lot of interest in looking at priority populations, and that will be on later this year, but we'll provide some definite dates in future. Just a final reminder, if you have found anything difficult or disturbing, please reach out to a trusted friend, colleague, or one of the support numbers that we've listed in the chat. But look, thank you all very much for attending, and that's the end of the session. See you all later.